Anemia. Reduction in the total number of erythrocytes in the circulating blood or a decrease in the quality or quantity of hemoglobin. Anemias result from impaired erythrocyte production, blood loss, acute or chronic, increased erythrocyte destruction, or a combination of three other factors. They're classified by their causes or changes that affect the size, shape, or substance of erythrocytes. So, cystic refers to cell size, chronic refers to hemoglobin content. Anisocytosis is assuming various sizes. Poikilocytosis is various shapes. So clinical manifestations, the main alteration of anemia is reduced oxygen carrying capacity and tissue hypoxia. Symptoms vary depending on the compensation, so mild to moderate anemia, which is gradual and easier to compensate. It may only cause problems during physical exertion, with more pronounced symptoms and alterations. Specific organs and inability to compensate may become more apparent. Compensation involves cardiovascular, respiratory, and hematologic systems. Initial compensation for cellular loss is the movement of interstitial fluid into the blood. So this results in an increase in plasma volume to maintain adequate levels, but the viscosity or the thickness decreases. So thinner blood moves faster than normal, causing a hyperdynamic circulatory state. So cardiovascular changes occur, so increased stroke volume and an increased heart rate. So this could lead to cardiac dilation, heart valve insufficiency if the underlying anemic condition is not corrected. Hypoxemia causes dilation of arterioles, capillaries, increasing blood flow. The increased rates can lead to heart failure, decreased oxygen levels, increased rate of breathing, an effort to increase oxygen availability, causing shortness of breath or dyspnea, a rapid pounding heart rate, dizziness, fatigue. So chronic cases, the symptoms may only be felt during physical exertion, and in severe cases at rest. So skin, mucous membranes, lips, nail beds appear blue due to reduced hemoglobin, or yellow or jaundice appearance due to red cell destruction. So that would be hemolysis. Tissue hypoxia causes early graying and thinning of the hair. Nervous system manifestations are caused by a deficiency of vitamin B12. Myelin degeneration occurs, causing paresthesias, gait disturbance, weakness, spasticity, and reflex abnormalities. GI symptoms include abdominal pain, nausea, vomiting, anorexia. Acute or severe onset, such as hemorrhage, has an initial compensatory mechanism of peripheral blood flow constriction, diverting the blood flow to essential vital organs. This decreased flow detected by the kidney activates the renin-angiotensin response, which causes salt and water retention to increase blood volumes. These are emergencies and require immediate intervention. Iron deficiency anemia is the most common nutritional disorder worldwide in both developed and underdeveloped countries. Most common in the United States, particularly in toddlers, adolescent girls, women of childbearing age, also those living in poverty. Infants consuming cow's milk due to decreased bioavailability of iron, and older individuals ingesting restricted diets, teenagers with poor diets such as junk food. The causes of iron deficiency anemia include dietary deficiency, impaired absorption, increased requirement, chronic blood loss, impaired absorption, and chronic diarrhea. Other causes can include medications that cause GI bleeding, surgical procedures that decrease stomach acidity and other functions, as well as eating disorders, excessive menstrual bleeding, ulcers, hiatal hernia, esophageal varices, cirrhosis, hemorrhoids, ulcerative colitis, or cancer. Parasitic infections that result in blood loss and iron loss are found in children in developing countries. H. pylori impairs iron uptake. So, hypochromic microcytic anemia occurs when iron stores are depleted, and both conditions, depleting iron stores, reduce hemoglobin synthesis, causing metabolic disorders. This leads to insufficient iron delivery to bone marrow or impaired use within the marrow. Iron is recyclable, so the body can maintain a balance in hemoglobin that is storage available for future hemoglobin synthesis. Blood loss disrupts this balance by creating a need for more iron, depleting the iron stores more rapidly, causing an immune function by regulating several immune mechanisms. Acquired hypothermia, the deficiency of iron in the blood may be part of the body's response to infection, which hampers cell growth. Idea, what is that supposed to mean? Oh, I think that was supposed to be IDA, iron deficiency anemia. So IDA occurs when the demand for iron exceeds the supply and develops slowly over 3 overlapping stages. So stage 1 is characterized by a decreased bone marrow iron stores, and hemoglobin and serum iron remain normal. Number 2 is iron transportation to the bone marrow is diminished. This results in iron deficiency erythropoiesis. And number 3 begins when small hemoglobin deficient cells enter circulation to replace the normal aged erythrocytes that have been removed from circulation. This is when the manifestations of iron deficiency anemia appear. So clinical manifestations begin gradually, and individuals tend to not seek medical attention until the hemoglobin decreases to about 7 or 8. Early symptoms include fatigue, weakness, shortness of breath, pallor, pale earlobes, palms, conjunctiva. Conditions progress and become more severe and epithelial tissue. Coilenchia or spoon-shaped fingernails, and they become brittle, thin, coarsely rigid as a result of impaired capillary secretion. Other symptoms include scaling and fissures of the mouth known as chelosis, stomatitis or inflammation of the mouth, and painful ulcerations of the buccal mucosa and tongue. Characteristics of burning known as glottitis. Burning mouth syndrome may be secondary to many disorders such as extremely dry mouth, infection, autoimmune disease, nutritional deficiencies, and other conditions. Difficulty swallowing or dysphagia is associated with an esophageal web. A thin concentric expansion of normal esophageal tissue consisting of mucosa and submucosa at the junction between the hypopharynx and esophagus. It's worsened by hyposalivation. Additional symptoms include gastritis, neuromuscular changes, headache, irritability, tingling, numbness, and visual motor disturbances. Cognitive impairment may be long-lasting and irreversible. So, diagnosis is based on symptoms and decreased levels of hemoglobin and hematocrit, accompanied by lower levels of normal serum iron, ferritin, and transferrin saturation levels. Let's see. What are you trying to say here? Scan, a sensitive indicator of heme synthesis, is the amount of free erythrocyte protoporphyrin within erythrocytes. Initial step is to treat iron deficiency anemia by identifying and eliminating the source of blood loss. Parental iron replacement for uncontrolled blood loss, intolerance to oral iron replacement, intestinal malabsorption, or poor adherence to oral therapy. Iron replacement is required, and hematocrit levels should improve within 1 to 2 months of therapy. Serum ferritin levels is a more precise measurement of improvement. Rapid decrease in fatigue, lethargy, and other associated symptoms is generally seen within the first month of therapy and may continue for many months. Menstruating females may need daily oral iron replacement until menopause. Pernicious anemia. This is a type of megaloblastic anemia. It's caused by vitamin B12 deficiency, and it's associated with end-stage type A chronic atrophic immune gastritis or autoimmune gastritis that impedes production of IF, which is required for vitamin B12 uptake in the gut. Means highly injurious or destructive and reflects the fact that this condition was once fatal, commonly affecting individuals older than 30 of Northern European descent. The main disorder is the absence of IF, which is excreted by gastric cells and forms a complex with B12 in the small intestine, which is essential for nuclear maturation and DNA synthesis in RBCs. The deficiency may be congenital or autoimmune process against gastric parietal cells that is a genetic disorder with an autosomal recessive inheritance pattern. An example is autoimmune polyendocrinopathy, which is a cluster of autoimmune diseases of the endocrine organs such as thyroiditis and type 1 diabetes mellitus. Other causes include surgical removal of the stomach, resection of the ileum, tapeworms, pregnancy, hyperthyroidism, chronic infection, disseminated cancer. H. pylori may cause an increase in antibodies that bind and damage the parietal cells. Environmental conditions may contribute to chronic gastritis, including alcohol use or hot tea ingestion and smoking. The susceptibility to develop pernicious anemia shows the relationship between innate immunity, such as gastric mucosal atrophy, hydrochloric acid, pepsin, and IF. So, pernicious anemia develops slowly over 20 to 30 years. So, by the time it's detected, it's usually severe. Early symptoms are often ignored due to them being vague, such as infections, mood swings, GI, cardiac, or kidney ailments. When the hemoglobin drops to 7 or 8, classic symptoms include weakness, fatigue, paresthesia, weight loss, and a sore tongue that is smooth and beefy red. The skin may become lemon yellow. Sallow would be the name for that, caused by a combination of pallor and jaundice. Hepatomegaly, indicating right-sided heart failure as well. Neurological symptoms result from nerve demyelination that produce neuronal death. Spinal column cord may be affected, causing loss of position and vibration sense, ataxia, and spasticity. These complications pose serious threat, but if not treated appropriately, symptoms are irreversible, and the cerebrum is involved with manifestations of depression and Alzheimer's disease. Diagnosis is based on manifestations and test results, including bone marrow aspiration, serologic studies, and gastric bypass. The presence of circulating antibodies against parietal cells and IF is useful. Gastric biopsy reveals total achlorhydria, which is the absence of hydrochloric acid, which is diagnostic for pernicious anemia. Treatment of choice is replacement of vitamin B12, such as weekly injections until deficiency is corrected, followed by monthly injections for the remainder of the individual's life. Effective treatment is determined by a rising reticulocyte count, returning blood counts to normal within 5 to 6 weeks. Pernicious anemia cannot be cured, so maintenance therapy is lifelong. If oral doses are administered of B12 at high doses, that can also be effective. Untreated, it's fatal, related to heart failure, and treatment decreases mortality significantly. Anemia of chronic disease, also called anemia of inflammation, which is a mild to moderate anemia resulting from decreased erythropoiesis and impaired iron utilization in individuals with conditions of chronic systemic disease or inflammation like infection, cancers, or autoimmune disease. It's a common type of anemia in hospitalized individuals. It develops after 1 to 2 months of disease activity. Initial severity is related to the underlying disorder and usually does not progress. Patients may be asymptomatic or may be an incidental finding. It shares features with COPD. People with acute illness or after acute events such as major surgery, severe trauma, MI, and sepsis, and some cancers. One of the most common conditions encountered in medicine and secondary to IDA. So the pathophysiology results from a combination of decreased erythrocyte lifespan, suppressed production of erythropoietin, altered iron metabolism, iron dynamics in macrophages. During chronic inflammation, a large variety of cytokines are released by lymphocytes and macrophages in the affected tissue. Impaired iron metabolism is partially the result of iron sequestration, and erythrocyte destruction is the result of erythropoiesis. Normal iron transportation by transparent may be decreased as a result of inflammation-related increases in the levels of circulating lactoferrin and apoferritin. During inflammation, neutrophils release lactoferrin to bind iron and reduce its availability for bacteria. Lactoferrin-bound iron is removed by the mononuclear phagocyte system, and it's converted into ferritin, the storage form of iron. The erythropoietic defect in ACD is failure to increase erythropoiesis in response to decreased number of erythrocytes resulting from diminished production of erythropoietin by the kidneys. So the clinical manifestations of anemia of chronic disease: mild to moderate in severity, significant drop in hemoglobin levels. Clinical manifestations of IDA appear. So very similar to iron deficiency of anemia. Evaluation and treatment, it's normocytic, normochromic, but with persistence becomes hypochromic and microcytic. Abnormal iron metabolism, low levels of circulating iron, reduced levels of transferrin. The most significant finding is a very high total body iron storage, even though inadequate iron is released from the bone marrow. So, the first indication of ACD is failure to respond to normal iron replacement therapies and frequently present with low or normal total iron binding capacity, normal or high serum ferritin levels, and low concentrations of soluble transferrin receptor. Use of erythropoietin in treatment of ACD, anemia of chronic disorder, is associated with arthritis malignancies, AIDS, and has been met with limited success. Patients with severe anemia secondary to chronic kidney disease can be treated successfully with erythropoietin and treatments to increase iron stores. Optimal degree of restoration has not been determined. A return of normal level increases the risk of hypertension, stroke, and death. Transfusion of critically ill individuals may worsen the outcome, increase morbidity and mortality. The principal treatment is easement of the underlying disorder. So, thalassemia. Thalassemia, alpha and beta, are autosomal recessive disorders that result in impaired synthesis of one of the chains. Beta thalassemia is more common than alpha, and both alpha and beta are classified as minor or major. The anemic manifestation of both alpha and beta thalassemia is microtychipochromic hemolytic anemia. So, the pathophysiology, beta thalassemias are caused by mutations that decrease the synthesis of B globulin chains, leading to anemia, tissue hypoxia, and red blood cell hemolysis. Chain production is depressed moderately in heterozygous form, beta thalassemia minor, and severely in homozygous form, beta thalassemia major. As a result, erythrocytes have a reduced amount of hemoglobin and free alpha chain accumulation. There are 4 types of alpha thalassemia. Alpha trait, which is heterozygous carrier state in which a single alpha chain forming gene is defective. Alpha thalassemia minor, in which 2 genes are defective. Hemoglobin H disease, in which 3 genes are defective, and alpha thalassemia major, in which all 4 A forming genes are defective, which is often fatal, often in utero, because alpha chains are not produced and oxygen cannot be released into the tissues. Clinical manifestations: beta minor causes mild to moderate microcytic hypochromatic anemia. The degree of reticulocytic depends on the severity of the anemia and results in skeletal changes. Serum iron and indirect bilirubin levels may be slightly elevated if hemolysis of immature cells has occurred and can have mild splenomegaly, bronze coloring of the skin, and hyperplasia of the bone marrow, but are less likely to experience life-threatening complications. Beta major may become quite ill and show impaired physical growth and development with severe anemia resulting from this condition, can cause a significant cardiovascular burden, high output congestive heart failure, liver enlargement, enlargement of the spleen by hemopoiesis, increased destruction of RBCs. Skeletal changes begin in infancy. It's spinal impairment that retards linear growth and upper and lower limb length discrepancy. facial bones become deformed and result in a chipmunk-like facial appearance. People who inherit the mildest forms are usually asymptomatic or mild clinical manifestations that mirror those of minor. So evaluation is based on familial disease history, clinical manifestations, and blood tests. Diagnostic tests include peripheral blood smears, hemoglobin electrophoresis. Prenatal diagnosis is sometimes done in families and are referred for genetic counseling. Newborn screenings include screening for thalassemia, and molecular genetic tests of at-risk siblings should be offered to allow for early diagnosis and appropriate treatment. Treatment is largely supportive and involves regular transfusion program, insulation therapy to reduce transfusion iron overload. The only available definitive cure for thalassemia major is allogeneic hematopoietic stem cell transplantation from a donor. Hemolytic anemia. It is premature accelerated destruction of erythrocytes, either episodically or continuously. It's acquired by infection, systemic disease, drugs, or toxins, liver disease, kidney disease, abnormal immune responses. Hereditary, caused by abnormalities of RBC membrane or cytoplasmic contents present at birth. Hemolysis in blood vessels or lymphoid tissue that filter blood, such as the spleen and liver. Erythrocytes are rigid, slowing their passage and making them vulnerable to phagocytosis. Types: warm antibody disease mediated by IgG antibodies specific for erythrocyte antigens. Cold antibody disease mediated by IgM and drug-induced. Clinical manifestations: splenomegaly, jaundice, aplastic hemolytic, or megablastic crisis can develop with viral infection. With severe disease, bones become deformed and pathological fractures occur. Cardiovascular and respiratory manifestations correspond with the severity of anemia. Sickle cell anemia, it's a group of autosomal recessive disorders. It's characterized by the production of hemoglobin S within the erythrocytes and is formed as a result of a genetic mutation in which one amino acid, valine, replaces another, glutamic acid. Under conditions of decreased oxygenation, tension, and dehydration, hemoglobin S stretches and elongates, causing the erythrocyte to assume a cyclic shape. These cells die prematurely, resulting in hemolytic anemia. The most prevalent types of sickle cell diseases are sickle cell anemia, sickle cell thalassemia disease, and sickle cell hemoglobin C. If 2 copies of hemoglobin I'm thinking in a child, must be what that is, present with sickle cell anemia, which is homozygous inheritance, in which the child's hemoglobin is mostly hemoglobin S. If one parent hemoglobin S and the other has a defective or insufficient alpha or beta chains of hemoglobin, the patients develop sickle cell Felicia disease. If one parent has hemoglobin X and the other is hemoglobin C or D, patients develop sickle cell hemoglobin C disease. If one parent is hemoglobin S and the second parent has normal hemoglobin, the patient carries the sickle cell trait and does not possess the disease. The pathophysiology: hemoglobin is soluble and usually causes no problem when properly oxygenated. When oxygen tensions decrease, the abnormal B globin chain polymerizes, forming abnormal fluid polymers. As these realign, they cause the red cells to form in a cyclic shape. Decreased oxygen and pH, as well as dehydration, trigger the sickling process. Acute illness, stress, temperature change, and living at an altitude can cause decreased oxygen tension. Sickled cells plug blood vessels, increasing the viscosity of the blood, which slows circulation and causes vascular occlusion, pain, and organ infarct. Increasing the blood viscosity also increases the time erythrocytes are exposed to less oxygenation. This further promotes the sickling. These cells undergo hemolysis in the spleen and become sequestered. They're causing blood pooling and infarct of the splenic vessels. Sickling is not permanent and gain a normal shape after reoxygenation and rehydration. So, clinical manifestations, some individuals have mild symptoms and others suffer from repeated vaso-occlusive crisis. General manifestations include pallor, fatigue, jaundice, and irritability. Extensive sickling can precipitate 4 types of acute crisis. So, vaso-occlusive crisis occurs with sickling in the microcirculation, causing vasospasms and a logjam effect. It blocks all the blood flow through the vessel. On the last process, reverse thrombus and part of local tissue occur. It's extremely painful, lasts days to weeks, with an average duration of 4 to 6 days. This crisis is variable and unpredictable and can lead to stroke or end-stage renal disease. Sequestration crisis is usually seen in children less than 5 years of age, where a large amount of blood becomes pooled in the liver and spleen with a high risk of mortality. The condition is not recognized and managed appropriately. Aplastic crisis is profound anemia caused by lower erythropoiesis, where survival rate of erythrocytes is only 10 to 20 days. Normally, the bone marrow is able to compensate, but when this response is compromised, such as after a viral infection, aplastic crisis develops lasting 7 to 10 days. Hyperhemolytic crisis, this occurs in association with certain drugs or infections, as well as acute or chronic reactions following a blood transfusion. Symptoms usually appear after 6 months of age. Infection is the most common cause of death related to sickle cell disease. Sepsis and meningitis develop within the first 5 years of life, and 10% of children. So, evaluation and treatment, parents' history, and clinical manifestations may suggest a child has sickle cell disease, but hematological tests are necessary for diagnosis. Prenatal diagnosis can be made after 15 weeks gestation by amniotic fluid and is now part of routine newborn screenings. Sickle cell trait typically does not affect the life expectancy or affect daily living. Supportive care emphasizing preventing consequences of anemia and avoiding crisis, including adequate hydration, infection prevention, and pain management help decrease morbidity and mortality. Genetic counseling and symbological support are important for the child and family. A common treatment for sickle cell disease is hydroxyurea, which inhibits DNA synthesis, which causes an increased hemoglobin F concentration and provides an anti-inflammatory effect by increasing leukocyte production, thought to decrease prices, to decrease something. Transfusion therapy can decrease morbidity and mortality associated with sickle cell disease, particularly in those with an increased risk for stroke. ITP. ITP is the most common cause of thrombocytopenia. So ITP idiopathic thrombocytopenia, secondary to increased platelet destruction. It increases with age, may be acute or chronic. The acute is frequently observed in children and lasts 1 to 2 months with a complete remission. In some cases, up to 6 months with some children, and may progress to chronic condition. Acute ITP is usually secondary to infections, particularly viral or conditions that lead to large amounts of antigen in the blood, such as drug allergies or SLE. The antigen usually forms immune complexes with circulating antibodies and binds to receptors on platelets, leading to their destruction in the spleen. It usually resolves when the source of the antigen or infection is removed from drugs. Chronic ITP is caused by antibodies against platelet-specific antigens, commonly in adults and most prevalent in women 20 to 40 years of age. It tends to get progressively worse, has no known risk factors, and can come from a primary predisposing conditions. The autoantibodies are generally of the IgG class and are against one or more several platelet glycoproteins. Antibodies bind directly to the platelet antigens, after which the antibody-coated platelets are recognized and removed from circulation by macrophages in the spleen. So clinical manifestations range from minor to major bleeding problems, development of petechiae and purpura over the course of several days, a major hemorrhage from mucosal sites such as epistaxis, hematuria, bleeding gums. Rarely will an individual present with intracranial bleeding or other sites of internal bleeding. During pregnancy, a woman can have a newborn that is also thrombocytopenic if the fetal platelets express the same antigen as the mother, resulting in thrombocytopenia in utero. Evaluation and treatment, it's based on history of bleeding and associated symptoms such as weight loss, fever, headache, physical exam, evidence of infection such as bacterial, HIV, and other viral, medication history, family history, and evidence of thrombosis are assessed. Diagnostic tests include CBC, peripheral blood smear, although most cases of ITP are associated with elevated levels of Ig on platelets. Others also have a high incidence of platelet-associated antibodies, and some will not be present with elevated and thus cannot rule out ITP. The acute form resolves without major consequences, but the chronic can result in multiple readmissions and exacerbations. Treatment is palliative, not curative, and focuses on prevention of platelet destruction. Initial therapy is prednisone to suppress the immune response and prevent sequestering and further destruction. If steroid therapy is ineffective, other treatments such as IVIG is used to prevent major bleeding. Splenectomy is considered to remove the site of platelet destruction if previous therapies fail. It can still cause relapse and require further treatment, and unsuccessful splenectomy, more aggressive immunology suppression medications are recommended. Leukemia. Clonal malignant disorder of the bone marrow, and usually but not always of the blood. Common pathological feature of all leukemias is an uncontrolled proliferation of malignant leukocytes, causing an overcrowding of bone marrow and decreased production and function of normal hemopoietic cells. Chromosomal abnormalities and translocation are common. The WHO or groups lymphoid neoplasms into 5 categories defined by the cells of origin. So number 1 is precursor B cells. Number 2, peripheral B cells. Number 3 is precursor T cells. Number 4 is peripheral T cells and natural killer cells. And then number 5 is Hodgkin lymphoma. Acute leukemia is characterized by undifferentiated or immature cells, usually a blast cell. The onset of the disease is abrupt and rapid. Without treatment, the disease progression results in a short survival time. Chronic leukemia, the predominant cell is more differentiated but does not function normally, and it is slow progression. So there's 4 types of leukemia: acute lymphocytic, which is ALL, chronic lymphocytic, CLL, acute myelogenous, AML, chronic myelogenous, CML. CLL and AML are the most common types in adults. CML is found mostly in adults. Risk factors for the onset of leukemia include environmental factors, genetic factors, and other diseases. So the pathophysiology: clonal disorders driven by genetically abnormal progenitor cells or stem like cancer cells. Majority are B cell in origin, followed by T cell tumors and rarely non-killer cell tumors. Abnormal immature white blood cells called leukocytic blasts fill the bone marrow and can spill into blood, literally crowding out the bone marrow, and can cause cellular proliferation of the other cell lines to decrease or cease. Normal monocytic, lymphocytic, erythrocytic, and megakaryocytic progenitor cells cease to function, leading to pancytopenia, which is a reduction of all cellular components in the blood. Genetic translocation or mitotic errors are observed in leukocytic cells. The most common genetically abnormality is reciprocal translocation between chromosomes 9 and 22. The Philadelphia chromosome was first observed in persons with CML and result in the translocation and the novel fusion, which results in expression of unique fused oncoprotein. In majority of cases, leukemic cells are injected into the blood where they accumulate and infiltrate the liver, spleen, lymph nodes, and other organs throughout the body. Acute leukemias, ALL and AML. ALL is an aggressive, fast-growing leukemia with too many lymphoblasts or immature white blood cells found in blood and bone marrow. AML is a grass fast. I bet that's supposed to be aggressive. AML is an aggressive, fast-growing leukemia with too many myeloblasts or immature white blood cells found in the bone marrow and blood, and is the most common of the acute leukemias. Increased risk for ALL is linked to exposure to X-rays before birth, postnatally, exposure to ionizing radiation, past treatments with chemotherapy, and certain genetic disorders. There's a family link and increased risk with exposure to cigarette smoke. Infections with HIV or Hep C virus increase the risk. AML is the most frequently reported secondary cancer after high doses of chemo, after Hodgkin lymphoma, multi-myeloma, ovarian, and breast cancer. Pathophysiology progresses from malignant transformation of B or C cells, such as stem cells. Most all ALL occur in children and often in the first decade. Adults with this have a higher mortality rate due to the biology of the disease. It's associated with chromosomal aneuploidy of various types. Adult ALL is a mixture of B and C cells. The mutations and their identification are ongoing. AML is the most common adult leukemia where genes are altered that encode transcription factors needed for myeloid differentiation. The bone marrow and peripheral blood are characterized by leukocytes and the prominence of blast cells with an increase in these immature blasts. They displace normal blood cells, leading to complications of bleeding, anemia, and infection. Down syndrome, aplastic anemia, Bloom syndrome increases the risk for AML. Clinical manifestations within days to a few weeks of the first symptoms and zebra stormy onset. More prevalent in ALL. I'm not sure what that's supposed to say. Zebra stormy onset. Anyways, more prevalent in ALL. Anemia, bleeding such as purpura, ecchymosis, hemorrhage, and petechiae, infection, weight loss, bone pain, liver, spleen, and lymph node enlargement. Elevated uric acid levels are found. Infection sites include the mouth, throat, respiratory tract, lower urinary tract, and skin. May stem from E. coli, Pseudomonas, Klebsiella, pneumonia, and fever is early. Sinus often accompanied. I don't think that's supposed to say sinus. Fever is early signs, often accompanied by chills. Evaluation and treatment is made through examination of blood cells and bone marrow. Bone marrow aspiration should be done by experienced oncologists, hematologists, hemopathologist, or general pathologist experienced in obtaining samples. Chemotherapy is the treatment of choice for leukemia. Other types of treatment include radiation therapy, chemotherapy with stem cell transplants, and other drug therapy. Supportive measures include blood transfusions, antibiotics, antifungals, and antivirals. It's critical that stem cell transplants be done in hospitals. Complete remission requires aggressive treatment and is divided in two phases: remission, induction to obtain remission, and post-remission to maintain remission. Chronic leukemias. CML can occur depending on the lineage of malignant cells, a slow progressing disease with too many blood cells that are not lymphocytes made in the bone marrow. CL is the most common leukemia in the Western world, slow-growing cancer in which too many immature lymphocytes are found mostly in the blood and bone marrow and differ only in the amount of proliferation of peripheral blood lymphocytes. CML is mostly an adult but can occur in children and have a longer life expectancy, usually extending several years from time of diagnosis. Pathophysiology. Clonal and arise from hematopoietic stem cells. Cells observed in CML are heterogeneous in differentiation depending on the stage of the disease. During the chronic phase, the predominant cell is long-lasting hemopoietic stem cell. The Philadelphia chromosome is present in 95% of persons diagnosed, and the BCR-ABL1 protein is responsible for initiation of CML. CLL involves malignant transformation and progression, accumulation of B lymphocytes that accumulate in the bone marrow and do not interfere with normal blood cell production. The significant feature makes explaining the reduced severity in the beginning stage of the disease. The major pathophysiological defect in CL is a failure of B cells to mature into plasma cells that synthesize immunoglobulins. Clinical manifestations advances slowly and insidiously, usually asymptomatic at the time of diagnosis. When symptoms do appear, the most common is lymphadenopathy, lymphadenopathy. The most significant side effect of CLL is suppression of the humoral immunity, increased infection with encapsulated bacteria, invasion of lymph nodes, liver, spleen, and salivary gland is common. CNS involvement is rare. CML progresses through 3 phases lasting 2 to 5 years, where symptoms may not be apparent. An accelerated phase of 6 to 18 months, during which primary symptoms may develop in a terminal blast phase or crisis with a survival of only 3 to 6 months. Accelerated phase is characterized by excessive proliferation and accumulation of malignant cells. Splenomegaly, liver enlargement, hyperuricemia, infections, fever, and weight loss are often present. The terminal blast phase is characterized by rapid and progressive leukocytosis with an increased number of basophils. Evaluation and treatment, laboratory analysis of peripheral blood and bone marrow. Diagnosis of CLL is based on detection of a monoclonal B cell lymphocytosis in the blood. Cells must have the characteristic immunophenotype at levels in excess of 5,000 cells over a sustained period, usually 4 weeks. Treatment of CLL includes treatment of infection, hemorrhage, or immunological complications. For individuals with progressive CLL, treatment and conventional doses of chemotherapy is not curative. Some individuals are treated with stem cell transplantation, common anti-leukemic therapy. Treatment must be individualized based on clinical behavior of the disease. Complications of pancytopenia, hemorrhage, infection is the major cause of death. Survival is 10 years or more. Multiple myeloma. Actually, I'm going to stop and I'll do the others on another one.